Hello, future nurses. I'm going to try to go through this super fast and just do a quick review of schizophrenia and the spectrum disorders. That way you don't have to listen to the whole recording of the lecture from the other day. So chapter 12 is where we start to see schizophrenia. So this is not too common. It only affects 1% of adults. However, we do see that gradual development between the ages of 15 and 25. So this is not a sudden onset. We can see childhood onset and we can see late onset in those 35, 40 years old. But generally speaking, if you've made it to middle age, give yourself a pat on the back. We will not have schizophrenia. All of these patients have one psychotic symptom: hallucinations, delusions, disorganized thought, and speech. And remember, those are called our positive symptoms. This affects your patient in every area of their life: hygiene, nutrition, healthcare, socialization, family. It is a completely invasive disease process. So these are our DSM criteria for schizophrenia. So your patient will have at least one psychotic symptom. And our psychotic symptoms are pretty much going to be our delusions, our hallucinations, our disorganized speech. We'll talk about the rest of these. To have that diagnosis of schizophrenia, it continues for at least 6 months. So this is not a one and done super fast. This disruption in their life is continuing for 6 months. Again, childhood onset is rare. There is no difference when we talk about race, social status, or culture. It affects everyone equally. We do tend to see it more in males in urban areas. Most often, that first schizophrenia experience is in college students between the ages of 18 and 24. Males, it does tend to start at a younger age. They're definitely going to push that 18, 20, 24. Females are where we tend to see it start 24 to 30. Females, it starts a little bit later. Comorbidity, substance use, particularly alcohol and marijuana, are nearly half of those affected. And your patients are more likely to be non-adherent with treatment. Increased rates of relapse of substance abuse, homelessness, violence, suicide, poor prognosis, especially when tied with that substance abuse. 60% use nicotine, and often it's a coping skill. It's helping with their anxiety, because anxiety, depression, suicide go hand in hand. 20% of individuals with schizophrenia will attempt suicide, while 5 to 10% will die by suicide, which is a rate higher than the general population. We do see changes in physical health, premature death. Generally, these patients have a life expectancy 20 years premature. So these individuals tend to pass away in the late 50s into their 60s. And we sometimes see polydipsia, excessive drinking of water, which leads to hyponatremia. And that can occur in about 25% of patients. Genetics is huge for schizophrenia, and we often overlook that. 80% of the risk, 80% comes from genetics or epigenetic factors. So this is a big one. If we have a patient who is first presenting with schizophrenic type symptoms, right, with that psychosis, ask about a family history. Because if they have a family history of schizophrenia, we pretty much can rule out that this, or rule in that this exacerbation is going to be schizophrenia. Neurobiology, dopamine. We talk about this when we talk about the medications. We see dopamine blockage decrease our hallucinogens, or hallucinations and delusions. We can see other neurochemicals come into play. Our second generation antipsychotics works by blocking serotonin and dopamine. Glutamate plays a role in psychosis. GABA is impaired in schizophrenia, and even acetylcholine. So our brain structures, we do see changes in the brain structure. We can do brain imaging, our PET scans, to see some of those differences in these patients. I have never seen where we actually did that, but it could happen. Psychological factors that can contribute to schizophrenia. Prenatal stressors, especially infection during pregnancy. There have been some wonderful longitudinal studies that look at the rate of schizophrenia in the population following a flu epidemic. because when the mother has influenza in that second trimester, the child has a greater risk of schizophrenia later in life. Having a father at the time of conception who is older increases the child's risk of schizophrenia. So we tend to see those rates, and honestly, even where late winter, early spring births tend to have greater rates of schizophrenia because the mother was pregnant during flu season. Cortisol, sexual abuse, poverty, migration, growing up in foreign cultures, social and psychological trauma, environmental stressors, certain dry cleaning solutions that we often see, the urban areas, high crime, all come into play. Prognostic considerations, most individuals, and I feel like prognostic considerations, it's a weird place to put this. Many individuals may improve with medications, but some patients do not completely improve. They will always have these mild residual symptoms, or they may even always have severe symptoms, even with the medications. So it's going to be a very wide range of varying degrees of dysfunction and disability. I'm going to skip through these. So delusional disorder. Delusions last longer than a month. Now this is different. We have been talking about schizophrenia. These are other psychotic type disorders. So delusional disorder, your patient has a delusion for longer than a month. And these delusions do not necessarily impact their function. Grandiose delusions, they have more money than they do. They have power that, they really don't have. Persecutory, someone is out to get me. Somatic has to do with our body. Referential, they mistakenly believe that ordinary events have hidden meanings just for them. The music on the radio is being played just for me. Brief psychotic disorder, again, this is separate than schizophrenia. You have a sudden onset of a delusion, hallucination, disorganized speech, and disorganized behavior. So you have at least one of the following for 1 day to 1 month. And then you potentially return to normal functioning. It is a time limit type, if we're looking at it by definition. You have this psychotic symptom, it lasts a month, it goes away, and it comes on suddenly. Schizophreniform is very much like schizophrenia, but the symptoms go away within 6 months. So schizophreniform would be 1 month to 6 months. We don't necessarily see impaired social functioning. We don't necessarily see impaired functioning with their work. And it's hard to know the prognosis of schizophreniform. Some patients return to their normal level of function, while others have difficulty and they kind of stay like that, and they may progress to schizophrenia. Schizoaffective disorder, again, different diagnosis. We have a mixture, and these patients meet the symptoms and criteria for schizophrenia as well as an affective disorder. So depression, bipolar. So this patient may have depression, this patient may have mania, and they also have schizophrenia. So we see a combination of symptoms. For some of the other psychotic disorders we talk about, this kind of puts it into play. Brief psychotic disorder is less than a month. Schizophreniform disorder is 1 to 6 months. And schizophrenia, the symptoms are present for greater than 6 months. Again, we have this other different form that looks at it. Brief psychotic disorder, 1 to 30 days. And they only have the psychotic symptoms. Schizophreniform, we have the period of psychosis for 1 to 6 months. We could have a negative symptom, unmotivated, that avolition. Schizoaffective disorder, schizophrenia, and a mood disorder. Schizophreniform, no negative symptoms, 1 to 6 months. And I think I said that backwards. Schizophrenia right here, 1 month of psychosis, greater than 6 months in the whole thing is schizophrenia. I apologize. In my head, it should have been brief psychotic disorder, schizophreniform, and then schizophrenia, and I have not finished my coffee. Phases of schizophrenia, prodromal, those mild changes in the beginning. And this can happen months to years before we see the acute period. Deterioration in concentration, they're struggling in school, they're struggling in their job, distressing thoughts, suspiciousness, maybe disorganization in speech or behavior. Something is not right with this patient. There's something strange going on. In the acute phase, this progresses later and we see mild to disabling symptoms. And in the acute phase is when we start to see hallucinations, delusions, along with the apathy, the social withdrawal, the disorganized behavior, cognitive regression, difficulty coping. Acute phase, the patient often will wind up hospitalized. In stabilization, the symptoms start to diminish and the patient is moving towards their previous level of functioning. In the maintenance or residual, we are now have a new baseline. Positive symptoms, so hallucinations and delusions may be absent, but the negative symptoms can continue. And this tends to go in a cycle, and the patients may have recurrent exacerbations, followed by periods in the residual phase. So your patient starts in that prodromal and goes to acute, and then from that acute phase, they go to residual, residual back to acute, acute to residual, residual to acute, and they can just cycle like that for a while. So what do we have to assess? Everything. We tend to see positive, negative, cognitive, and affective symptoms. We're going to talk through a lot about those. I know we had a whole lot of words. So our positive symptoms, you need to be able to differentiate between positive and negative symptoms. Positive symptoms are things where in a normal person, they don't exist, and we are adding them in. Positive is addition. Delusions, those false beliefs. We'll talk about a lot of alterations in speech, changes to our concrete thinking, and not on here, and I don't know why they're not on here, hallucinations. Seeing, hearing, feeling, touching, smelling things that are not present. So when we break down what are our positive symptoms, we have different alterations in speech. Word salad, most extreme form, it's just the jumble of words. Throat, horse, strength, policy, highlighters, banana, boat, reigns supreme. And you're like, I know what those words mean, but when you put them together, that sentence did not make sense. And that is word salad. Clang associations are words chosen based on sound. Click, clack, clutch, close, and your patient just rhymes. Neologisms. Your patient makes up words. They have meaning only for the patient. Echolalia, repetition. If we tell our patient to come get your medications, the patient's response will be, come get your meds, come get your med, come get your med. Other abnormal speech patterns, we've talked about a lot of these when we talked about bipolar. Circumstantiality, adding in a lot of unnecessary detail, and eventually you reach your point. Tangentiality, we go from topic to topic, but we never reach our point. Cognitive retardation is slowing of thinking. It might take longer to respond to questions. There may be delays in the conversation. Pressured speech, it's word vomiting. The words have to come out. They cannot stop them. Flight of ideas rapidly from one topic to the next. You cannot follow the conversation. And then symbolic speech. The patient may not always have the words to describe it, but they might be telling you that demons are sticking them with needles, when in reality, they're having a sharp pain in their back. Disorders of thought, I think these ones are pretty easy. Thought blocking, a reduction or stoppage of thought. They lose their thought. And oftentimes it could be an interruption by a hallucination. Thought insertion, your patient believes that someone else is inserting thoughts into their brain. Thought deletion is the exact opposite. They believe that someone is stealing the thoughts from their head or that their thoughts are missing. Magical thinking, their belief that their actions have consequences on others. So if I step on a crack, in magical thinking, I will truly believe that I will break my mother's back. Paranoia, we have talked about this before. Mild to profound, right? Mild, we are guarded, we are cautious. There are people out to get us. Profound, the CIA is following us and they are trying to kill me. So alterations in perceptions, again, these are all positive symptoms. that we see in schizophrenia. So depersonalization, outside of your body, feeling like your body parts don't belong to you. Derealization, it has to do with the environment, feeling like your environment has changed. Hallucinations, perceiving that sensory experience for which no stimuli exist. So auditory, hearing things that are not there. Visual, seeing things. Olfactory, smelling. Gustatory, tasting. Tactile, feeling things. Command hallucinations are the most concerning, and we always have to assess for command hallucinations because these voices are now telling your patient to do something. The voices are telling me to go kill Jack. Illusions, something's there, but we're misinterpreting it. The power cord on the floor is a snake. Again, still positive symptoms. Catatonia, increase or decrease in movement. Motor retardation, slowing of movement. Motor agitation, excited, running, pacing. We may often have an internal stimuli that is causing the agitation. Stereotype behaviors are repetitive that have no purpose. Waxy flexibility, we see this in catatonia. We could twist our patient into a pretzel, move their body into different shapes, and they stay like that. Echopraxia, we mimic other people's movements. Negativism is just what it sounds like. We're going to do the opposite of what someone asks us to do. Impaired impulse control, we cannot resist our impulses. Gesturing or posturing, assuming weird, unusual positions or facial expressions. And then boundary impairment, we don't see where our body ends and where another begins. So we may stand too close to a patient. The patient may stand too close to us. They're switching gears, the negative symptoms. So we have a normal person. When we're talking about schizophrenia, the negative symptoms are what we take away from that patient. So anhedonia, they cannot experience pleasure. Avolition, loss of motivation, inability to have goal-directed behavior. Asociality, decreased desire for social interaction. Affective blunting, we take away or we constrict their facial expressions. Apathy, they don't have interest. They will things that used to find interesting, activities they used to like to do are no longer interesting. Alogia, we take away their speech. Sometimes you hear that called poverty of speech. So again, when we talk about our negative symptom, this kind of just looks at that affect. So when we take away or constrict the affect, that is a negative symptom. So immobile or blank facial expression is our flat. Blunted, it's going to be minimal. They are making facial expressions, but it's not quite there. Inappropriate is incongruent. The patient's laughing when we're talking about a tragedy. Bizarre, it's just weird. They just have a very odd facial expression. So our cognitive symptoms. Cognitive has to do with thinking. It has to do with thought. Impaired thinking, they can't think abstractly. So if we tell this person, if we're talking concrete thinking, if they're jumping around all over the place and we say, do you have ants in your pants? They will freak out and start taking off their pants because they will think they have ants in their pants. They cannot understand the meaning behind ants in your pants. Impaired memory impacts short memory. It impacts your patient's ability to learn. Impaired information process, it takes them longer to understand. They may not be able to screen out insignificant stimuli. Impaired executive functioning, setting priorities, comparing options, putting things in order, anticipation, stopping undesirable impulses and actions, kind of fall into impaired executive functioning. Affective symptoms have to do with mood. So we have to look out for depression. We have to look at an increased risk of suicide. So one of the most serious affective changes we see in schizophrenia is depression. We can also see an erratic or labile mood. So labile will be changing rapidly, or incongruent, a mood that we would not expect to see given the circumstances. When we talk about self-assessment of both the patient and us, we have to remember our patients have something called anosognosia, and that's the inability to realize that they are ill. so they have no insight into the illness. And anosognosia is caused by the schizophrenia. So it makes your patient want to resist treatment or not participate in treatment. And when we combine that with paranoia, everyone's out to get me, it's almost impossible to help these individuals. As the nurse, we have to remember there is a lot of anxiety or fear. If you're working with a patient who is potentially violent, is paranoid, is aggressive, you can be scared, and that is okay. We can be frustrated if we are routinely trying to help a patient and they keep coming back. We need to make sure we're talking to staff, to our peers, everyone else is going on and helping process, our feelings too. Counter transfers, when we're putting those thoughts and feelings on our patient, we want to make sure we are avoiding those. So what do we have to look out for when we're assessing these patients? Any medical problems, because we can see drug and alcohol use disorders, brain injuries that could mimic psychosis. Include a cognitive assessment. Do that reality testing. Do they know what is real and what is not real? We have to assess for delusions, especially delusions and hallucinations, especially command hallucinations. We have to figure out what are the voices telling your patient. And I always talk about voices and auditory hallucinations. Auditory hallucinations makes up about 75-80% of all hallucinations. Then comes visual. Your olfactory, gustatory, tactile they're not as common. Assess for suicide always. Make sure they're taking their medications. Make sure they, what is their functioning? Can they do their ADLs? How is their family coming into play? Does everyone know what is going on? Can your patient get out of bed and shower? Are they eating? Potential nursing diagnosis, sensory perception, self or other directed violence, communication, isolation, low self-esteem. Again, it will always depend on what is going on with your patient. Our outcome identifications in the first phase, if we're talking about acute 24-hour support, this is going to GBHI. This is going to your lockdown unit. We want to prevent harm to self or others, structured therapy in the milieu. During stabilization, we want to get them take medications. We want them to adhere to treatment. We want to make sure they develop relationships with support providers. And then if we can, refer out to community-based therapeutic services to make sure treatment continues after they discharge. In the maintenance phase, we want to keep them from relapsing. We want them to have a satisfactory quality of life. We want them to be independent. So planning, again, it's going to depend on what's going on with your patient. A lot, especially in the maintenance phase, patient and family education. And we want to teach strategies in that maintenance phase to not relapse. Implementation in the acute phase. Psych evals, medications, psychoeducation, supervise in the milieu, set limits, make sure they're eating and drinking. And then aggression. We had a whole separate lecture on anger and aggression. Assess for risks, take those safety measures, call your friends, violence, agitation, if they are assaulting someone, right? We have to then use seclusion and restraint as that last resort. Stabilization and maintenance phase, meds have a relationship. Teamwork, safety, we've kind of already talked about this. And communications, we want to look at what is going on. Health promotion and health teaching goes along with relapse. Make sure you're eating, drinking, don't use substances, take your medications, managing the side effects of medications. There are a lot of things that can kind of come into play when it looks at these. I'm going to skip through this because we've pretty much talked about it. We did not talk about liver impairment on my medication slides. Just be mindful with these medications. We want to draw a AST, ALT, all your liver functions when we start the medications, and then periodically throughout. That I think is the one I forgot to add that in there. And I told myself the other day. So advanced practice, what is our nurse practitioner, PA, psychologist going to do? Therapy, individual and group. Get them interacting with other people's, educate them about their disease process, prescribe the medications and make sure they're taking it. Health assessment, again, does not necessarily always have to do with psychiatry. If we have a patient on an atypical antipsychotic, they may be monitoring their blood sugar, their liver functions, and involve the family in therapy. This is a hard disease process on everyone. Evaluate. We want to evaluate periodically and just treatment. This is evaluation is always ongoing. Even if symptoms improve, the patient's still recovering. This is a forever chronic illness. Small goals. When we set small goals, it helps your patient feel better because they achieve the goals. If we set some huge goal that's going to take a long time to meet, your patient can get discouraged. And we have to make sure we're showing our patient that we care and continuing to communicate. Quality improvement, this is our last slide. Evidence-based treatment. There are things that we used to do when I started as a nurse, which I will not talk about, that we don't do anymore. We have new research, we have new evidence, and we want to continue to include those in what we're doing. Making sure we're always assessing data, make sure our patients are always improving, and make sure we're staying up to the latest guidelines and latest evidence-based practice. That is it. If y'all have questions, let me know. Otherwise, I will see y'all Thursday.